Thank you, and thank you again, pgxecho, for the opportunity to present today on during the anniversary. It's an honor for us. So for this didactic portion, we'll be going over just briefly the pharmacogenomics program at Atrium Health, and then go into the review of serotonin syndrome and pharmacogenomic testing in serotonin syndrome cases. So first of all, I would just like to take a few minutes to give a brief background of our health system and pharmacogenomics program. Atrium Health is based in Charlotte, North Carolina, with a health system network serving patients at 40 hospital and over 1,400 care locations in North Carolina and South Carolina. Atrium Health has recently become part of Advocate Health, which is now the third largest nonprofit health system in the U.S. Our pharmacogenomics program is established under the Department of Cancer Pharmacology and Pharmacogenomics of Levine Cancer Institute. Our research spans across the translational and clinical research spectrum with a focus on oncology populations. So our research spans from gene discovery work, so primarily through genome-wide association studies, identifying genetic predictors of drug toxicity. We also perform candidate gene studies focusing on gene validation or replication. And lastly, we have prospective interventional PGX guided dosing trials, with some for specific drug gene pairs and others are multi-gene studies evaluating testing feasibility and impact on prescribing and quality of life. So for our clinical implementation program, we developed our first in-house clinical test in 2015, CYP2C19 for voriconazole dosing in post-allogeneic stem cell transplant. And then in 2020, our DPYD test for patients receiving fluoropyrimidine-based chemotherapy. In 2021, we developed our first in-house multi-gene panel for research for two of our prospective trials in the supportive oncology and stem cell transplant populations. And just last year, we developed and adopted clinical decision support in our new EHR Epic, which includes interactive alerts and passive warnings for over 50 drugs per CPIC and FDA guidance. And most recently this year, actually this week, we went live with DPYD orderable and billing Epic. So providers within Atrium Health who are interested in PGX testing that are outside of a research study can send us a consult via the EHR or email, and from which we will recommend, first of all, if PGX testing may be useful, depending on the testing indication, and then we will recommend a commercial test and coordinate test ordering. We have a team of 3 pharmacogenomics trained pharmacists, and so one of us will interpret the results and communicate the recommendations to provider with a consult note. And pharmacogenomic results are entered into the EMR as discrete data to trigger clinical decision support. So now, moving on to our topic today, serotonin syndrome is a predictable but potentially life-threatening condition caused by increased serotonergic activity in the peripheral and central nervous systems. So in the CNS, serotonin is found primarily in areas that are responsible for regulation of wakefulness, effective behavior, thermoregulation, muscle tone, etc. And then in the periphery, serotonin assists in the regulation of vascular tone and gastrointestinal motility, so, which may explain the clinical signs and symptoms that we'll discuss in a bit. So looking at this figure, serotonin is produced in the presynaptic neuron and is incorporated into vesicles until it's needed for neurotransmission. And upon axonal stimulation, serotonin is released into the intrasynaptic space where it binds to postsynaptic receptors. And so the hyperstimulation of postsynaptic serotonin receptor is what is causing serotonin syndrome. And among all of the different classes of serotonin, or 5-HT as noted on in this figure, among the different serotonin receptors, there's no single receptor that appears to be responsible for the development of serotonin syndrome, although the evidence is suggesting the serotonin 2A receptors that may be contributing substantially, and then followed by the serotonin 1A receptor. So patients may present with a spectrum of symptoms, often characterized by the clinical triad of mental status changes, autonomic hyperactivity, and neuromuscular abnormalities. So symptoms can range from mild symptoms to moderate to severe. Excuse me. Speaking of mental status changes, symptoms can range from anxiety, agitation, all the way to confusion or coma. With autonomic hyperactivity, that could include anything from tachycardia, hypertension, flushing, diarrhea, maldiasis, to a high fever, severe hypothermia. And then lastly, with neuromuscular abnormalities, that includes incoordination, of balance, and inability to stay still, as well as tremor, clonus, hypertonia, or hyperreflexia. And these symptoms, the symptom onset is usually rapid, so often within 12 to 24 hours following medication exposure or dose adjustment, and it can occur in all age groups. So serotonin syndrome can occur due to a number of causes, one of them being overdose of a serotonergic medication, whether that being intentional or accidental. The other cause is inadvertent drug interaction. So this could be either due to concurrent use of 2 or more serotonergic drugs, or due to addition of non-serotonergic drugs that inhibit the metabolism and increase the levels of other serotonergic medications. So some examples would be, CYP3A4, CYP2D6, or 2C19 inhibitors that can increase the drug substrate concentrations that have been reported in the literature to be associated with serotonin syndrome. And then lastly, any kind of organ dysfunction, such as renal dysfunction, can cause drug accumulation as well. So in this table, listed here are the examples of drugs associated with serotonin syndrome, classified by their mechanism. So just going through the list, these drugs can increase serotonin synthesis, with an example being tryptophan, which is a food supplement. Other drugs, so certain stimulants, cocaine, and MDMA, can increase serotonin release into the intrasynaptic space, and monooxidase inhibitors, MAOIs, or antibiotics like linezolid can inhibit serotonin metabolism. And then we have other drugs, so certain antipsychotic or opioids or antidepressants that are acting on the serotonin receptors. And then lastly, we have a decent amount of SSRI, SNRIs, TCAs, opioids, as well as the over-the-counter drug dextromethorphan that inhibit serotonin reuptake from the synaptic. However, the true incidence of serotonin syndrome is unknown due to difficulty with diagnosing, as there's no lab test to confirm the diagnosis, and mild cases can often be overlooked or dismissed, or are attributed to other causes. So a number of diagnostic criteria have been developed, though none is based on a pediatric population specifically. And one criteria commonly used in practice is the Hunter serotonin toxicity criteria, which was developed based on a large set of serotonin syndrome cases. So the workup is typically starts with the patient history. So any recent use or change of prescription or over-the-counter drugs, illicit substances, or dietary supplements that may have serotonergic activity. And then the next thing with physical exam is to identify clonus, which is defined as involuntary or rhythmic muscle contractions with reflex response. This being like the kind of the cardinal finding in establishing the diagnosis, as well as other symptoms such as tremor, hyperplexia, sweating, agitation. It's important to note that symptoms can be masked by concurrent medications or other comorbidities. So some examples being chronic opioid therapy use can mask diarrhea, and then use of multiple CNS depressants can affect the ability to kind of see the mental status changes. So as far as the workup, providers should consult with medical toxicology or pharmacology or their local poison control center, and to possibly consider pharmacogenomic testing if slow metabolism of drugs is suspected. So in terms of management of serotonin syndrome, the first thing is to discontinue any and all offending agents. And then supportive care remains the mainstay of therapy, and that includes correcting vital signs, so stabilizing blood pressure and pulse. Next being control agitation, if moderate to severe, with sedative agents. We have cyproheptadine, which is a serotonin HCR 5-HT2A antagonist. So it binds to about 90% of serotonin receptors. It is a first generation antihistamine. However, some limitations, it is an oral drug only, and so absorption may take a few hours, and so it's generally could be used in clinical practice. So the true effectiveness is not known. And then some other sedative agents that could be used are benzodiazepines, fixed methamphetamine. The next thing is to control hyperthermia, and this is using cooling techniques because there are no role for antipyretic agents, so Tylenol, for example, because the increase in body temperature in serotonin syndrome is due to excessive muscular activity, and so it's not an alteration in the hypothalamic temperature set point. And then lastly, to check for creatine kinase or CK to treat for rhabdomyolysis if needed. Many cases of serotonin syndrome can result within 24 hours with discontinuing the offending agent and supportive care management. Though some patients, it may take longer if the drug has a longer life. So moving on, what is kind of the role or the use of pharmacogenomic testing in serotonin syndrome? The HTR2A gene, which encodes the serotonin 2A receptor, it involves the two SNPs, so RS6313 and 6311, which have been associated with altered serotonin 2A expression, as well as affecting possibly psychotropic medication response and side effects. In a study by Murphy and colleagues that was published in 2003, they performed a randomized PGX study that compared treatment outcomes in elderly patients with depression. And so they performed a survival analysis in this graph here in patients on paroxetine. And the analysis showed that patients with the CC, homozygous with the CC genotype, were more likely to discontinue paroxetine due to more severe adverse events compared to the TC or TT genotype. And so this suggested the inter-individual pharmacodynamic differences at the serotonin 2A receptor gene that is affecting paroxetine intolerance, and so may potentially, predispose patients to developing serotonin syndrome. Another study by Cooper and colleagues in 2014 aimed to determine this association again, but was not able to find any significant differences, as they found that of 29% of their patients with serotonin toxicity, they had compared to about 25% without serotonin toxicity that had the CC genotype. So the evidence in this with this gene and SNP specifically at this time is still conflicting. We also have genetic polymorphisms that affect drug metabolizing enzymes, for example, CYP enzymes that can affect drug exposure and increase the risk of serotonin syndrome. And especially in a setting where many serotonergic drugs, antidepressants, for example, are metabolized by various CYP enzymes. So summarized here is a few case reports of serotonin syndrome in the literature in which pharmacogenomic testing was performed. So the first case report in 2008 was a case of a 60-year-old male with neuropathic pain who's being treated with hydromorphone, gabapentin, clonazepam, and amitriptyline. He was also started on dextromethorphan and 2 days later presented to the ED with profound coma. PGX testing revealed that he was a CYP2D6 poor metabolizer, and so just looking at the concurrent use of serotonergic drugs here being hydromorphone and amitriptyline, as well as dextromethorphan, which is a CYP2D6 major substrate. From this case, PGX testing could potentially or partially explain the causes. The other case report in 2017 in a 29-year-old female with depression and anxiety. She was started on fluoxetine with a dose titration, and shortly after presented to the ED with agitation, sweating, and tremor. And PGX testing showed that the patient was a poor metabolizer for both CYP2D6 and 2C. And as we know, fluoxetine is a minor substrate of both of these genes, amongst others. And so, while it's based on the most recent CPIP recommendation, there's no recommendation for fluoxetine based on genotyping, but in this case, the poor metabolizer status was suspected to be causing elevated levels of fluoxetine. And then most recently, another case report that was published earlier this year in a 17-year-old female with general anxiety disorder on buspirone, and then was added on fluoxetine with dose titration. And the patient presented to the ED with serotonin syndrome-like presentation. And pharmacogenomic testing showed that the patient had intermediate metabolism in the 2D6, 2C19, and 3A4 genes, which are involved in metabolizing fluoxetine, and with both buspirone, it is also a major 2D6 and 3A4 substrate. And so PGX testing again in here could potentially explain the possible elevated levels of both of these serotonergic drugs. So to kind of summarize, currently there's still limited clinical evidence regarding PGX testing performed in patients with serotonin syndrome, but these observations suggest a possible role of PGX testing in serotonin syndrome that can may be useful in predicting drug metabolizing status.